Welcome to today's webinar, Housing Child Trafficking Victims, a look at the national landscape. My name is Bailey Merrifield, and I am a research analyst for the Center for Victim Research. CVR and this webinar are supported by funding from the Office for Victims of Crime, the Office of Justice Programs, U.S. Department of Justice. The Center is a partnership between researchers and practitioners based at the Justice Research and Statistics Association, the National Center for Victims of Crime, and the Urban Institute. The Center's mission is to serve as a one-stop resource for victim service providers and researchers to connect and share knowledge to increase access to victim research and data, and the utility of research and data collection to crime victim services nationwide. Today's webinar will discuss key components of a specialized child trafficking response. And now it is my pleasure to welcome our presenters today. Amy Farrell, Associate Professor and Associate Director of the School of Criminology and Criminal Justice at Northeastern University. Sarah Lockwood, Doctoral Student in Criminology and Justice Policy at Northeastern University. And also Susan Goldfarb, Executive Director of the Children's Advocacy Center of Suffolk County in Boston, Massachusetts. And with that, I will hand it over to them.
Great, thank you, Bailey. And thanks everyone for joining the webinar today. I'm joined here with both Sarah and Susan, and would also like to acknowledge our other co-authors on this project. A team from the National Center for Youth Law helped to join us in this interdisciplinary collaboration on housing for child trafficking victims. All right, so jumping today into this project, this grew out of, as I said, a partnership between researchers at Northeastern University, a group of advocates at the National Center for Youth Law, and the Children's Advocacy Center of Suffolk County, who works directly with young people who are victims of crime. We were really interested in understanding the ways in which specialized housing services could be provided to children who've been identified as victims of trafficking. And part of this grew out of a struggle that we were having in Massachusetts to provide guidance to state systems about adopting best practices for housing. And we began looking around at the national landscape to see what was being done and what did we know about best practices. And found pretty quickly that while there seemed to be a lot of practices and there seemed to be a growing number of programs, there was very little research about best practices, very little understanding of the type of programs that were being provided to child trafficking victims in terms of residential settings. And we began to see that as there's an increased emphasis on responding to children who've been victims of trafficking within child welfare systems, there's a growing need to provide guidance to the field about what those specialized services should be within a residential setting, and which services would be best for which types of youth. So this collaboration was born after we realized that our partners at the National Center for Youth Law were also beginning to make some inquiries into this and had done some preliminary research. And we will provide a link to the report that came out of this partnership, as well as a link to some other research that the National Center for Youth Law has done on the topic of housing that will be circulated after the webinar. So this project really is focused on understanding what the landscape is for providing services within residential settings. And I'll give you a spoiler alert right now. We're not going to tell you what best practices are because we don't know. We basically found out through the course of this research that there is insufficient data to actually measure best practices at this point in time. There are a few programs that are collecting data, and we will talk more about that at the end of the presentation, that would allow us to begin to determine the efficacy of different types of practices for young people. And so we shifted focus sort of at the outset of this project and said, while we're not able to determine what best or maybe even promising practices are, we are able to determine what the practices are. And and gives a sense of what the landscape is of what people are doing around the country. So let me set the stage a little bit about where we began this project. This project took part in 3 phases. In the first phase of the project, we were really interested in saying, what are the state laws out there around child trafficking that would provide the provision of specialized services sort of in generally to children who'd been identified as victims of trafficking, and also specifically within child welfare or within residential placement systems. So we were able to identify that about a third of the states actually do have state laws that include specific provisions for specialized services for child trafficking victims. About 3/4 of the states identify sex trafficking as a form of child abuse and neglect when we began this study, and that number is higher now. And we actually found that there's obviously, as most people know, a range across the states of those states who both have safe harbor provisions which allow that children would not be arrested or charged for commercial sex offenses, either on their own or combined with the provision of specialized services. So we think this conversation about housing and the best practices that may exist out there in the field, or the practices that exist in the field, should not be completely decoupled from work that's being done around ensuring that children are not brought into the criminal justice system. And we'll start to see that when we look at the various ways in which residential programming is provided in terms of kids that have juvenile justice system involvement versus child welfare involvement. So once we had a landscape, that we were particularly interested in that about a third of states that specify within their state laws specialized services. And so we dug a little bit deeper to figure out what those services were and where the states were that were providing those services. And so we, in the second phase of the study, created a running list of all of the programs that we could identify that claim to provide specialized services to child trafficking victims within a residential setting. And we gathered that list by calling those states that had state laws that mandated the provision of services to see what the child welfare systems in those states actually did and where those young people went. We reviewed lists of placement that existed in public domains. We utilized online resources to look for programs in each state. We did chain referral in the sense that we had people refer us to other programs that they knew either in their state or in other states that housed and provided specialized services to child trafficking victims. And so we created this sort of growing list of 130 programs that we identified and sent a preliminary survey to that was rather short, about 10 questions, asking them to provide some basic information about what their program was, the types of child trafficking victims they served, and the context in which they served those victims. And particularly, we were interested in what aspects made their program specialized. In that preliminary survey, we had 92 programs that responded to and completed the survey, so a 71% response rate. There were some of those original 130 that had to be kicked out because they ended up only serving adults, they ended up being closed, they ended up not yet being open. There were some programs that were listed that we had identified that actually hadn't started serving kids yet. So we also found out that of the 92 respondents to the original preliminary survey, about 25 didn't actually meet our inclusion criteria because while they housed child trafficking victims, they did not provide any specialized services to those child trafficking victims. That is, they may have had beds where child trafficking victims stayed, but their programs were not specialized and they weren't tailored to meet the needs of child trafficking victims. So we identified 67 programs across the country who had specialized services that they provided for child trafficking victims or victims of commercial sexual exploitation oftentimes. And what you can see from the graphic that's on your screen are the density maps of states in terms of how many programs they had. So places like California, Florida, Minnesota had more programs, and then the dots are the blue dots are those that were part of our preliminary survey and that met our eligibility criteria, and those red dots were the ones that responded that they house youth, but we didn't include them in this analysis. And so I want to start by talking a little bit about sort of who these programs are and where they are. So what we find is that the overwhelming majority of these programs are in congregate care or residential placement in sort of group home models. There are some programs, about 13% of our sample, that were foster care, and a few that fell into sort of other models. But the vast majority of these programs were group home or congregate care facilities. The sort of primary funding mechanism was that these were private facilities that received money from state child welfare, either in a reimbursement basis or through grants to house young people. And many of the programs also had private funding in addition to funding that they received from public sources. And as we'll talk about later, some of that private funding was really key to the services, to the programs being able to offer additional services that really were specialized to child trafficking. We also found a range of programs in terms of whether or not the residential facility or the program itself only housed commercially sexually exploited children or child trafficking victims. About 2/3 of the programs were specialized in the sense that they only held that population, whereas a little over 1/3 of the programs were integrated. That is, child trafficking victims were housed in the same facility as other children that had not been identified as child trafficking victims, but in those programs, the child trafficking victims received different types of programming that was specialized to meet those needs. So in terms of the programs, we found that in terms of system involvement of the young people in these programs, overwhelmingly, young people in the programs were involved with child welfare. Many programs, about 77% of the programs that we interviewed, had some of the children that were involved in their program that were involved in the juvenile justice system. And about 69% had youth that were involved in the mental health system. So we're finding programs that actually house young people across a range of other state system involvement. About 1/3 of the programs either had the ability to serve male youth or would. They might not actually be serving male youth, but they could have. So 2/3 of them only served girls or young women. Just under half of the programs either served or had the capacity to serve foreign national youth. 46% of the programs had specific capacity to serve LGBTQ plus youth in terms of providing special programming. And 60% had some type of capacity to offer other languages than English to youth where English was a second language or the youth did not speak English. The primary second language was Spanish. We found that most of these programs that fell into that specialized provision of services programs were staff secured. There were a few programs, about 28%, that were unlocked, and about 10% of the programs were locked facilities. Those tended to be programs where the specialized services were entirely within the juvenile justice system, and so they were locked facilities. And we do see some variation in the program across these types of programs that are serving a heavily child welfare and very little juvenile justice involvement program to those programs that are predominantly or entirely serving youth in the juvenile justice arena. So after we got some of that very basic information on those programs we'd be able to identify across the country, we did in-depth interviews that were long, and some people who are on the webinar today may have in fact participated in some of those interviews. We picked 25 programs and ended up interviewing the either clinical directors or executive directors of 23 of those programs. So we picked 25 that we felt like, you know, really had longevity providing services. They didn't have just started providing services, they'd had experience. They were distributed across a range of states with the different types of sort of legal structures. And so you can see in this graphic the distribution of where we did those in-depth interviews. So we have pretty good geographic representation across the country. And there are some states, again, Florida, California, Arizona, where we interviewed multiple, Massachusetts, New York, multiple programs in a single state. So we did 23 in-depth interviews that were fairly long interviews. And I'm just going to talk about some of the highlights from those interviews. We collected a lot of data, a lot of detailed data about what these programs are doing, but we distilled this down into what we saw as being common practices across programs. So I would like to stress again, we're not saying these are necessarily best practices. They may turn out to be best practices once we have research that establishes that doing these things leads to better outcomes for young people. But right now what we know is that these are commonly held practices amongst those programs that claim to be and that do provide specialized services to child trafficking victims. And so I'm going to walk through the 5 components that we found commonly amongst this smaller sample of programs that had provided services for some period of time. And I'm going to talk through each of these individually. So I'll just very quickly give you an overview. We're going to talk a little bit about specific staffing policies that and programs that made this program specialized, the ability of the program to engage in a multidisciplinary team response, issues around the physical space of the facility, and discussion about specific practices and programming of the facilities, and a discussion about safety. So these 5 components really came out time and time again in interviews when we asked either about these things being done, or we asked respondents to talk about the things about their program that they thought made it different or specialized or specific to commercial sexual exploitation or child trafficking service provision. And they'll make more sense as I go through them. So the first component in staffing. So we found that in specialized programs, the staff of those programs had received additional training around commercial sexual exploitation, around trafficking, and around providing services to this population. About half of the programs had had specialized services, specialized training for a majority of their staff around trauma-informed care, and 64% had had training specific to commercial sexual exploitation. Now, that training varied dramatically across programs. Sometimes it was a day-long training for some of the staff. Sometimes it was multiple training sessions on an ongoing basis for all the staff. So there was quite a bit of variation, but having specialized training was certainly one of the major components that made these programs different. So it wasn't just a situation where you had a residential facility that housed young people where none of the service providers in that facility were trained, or maybe only 1 or 2 service providers in that facility were trained to respond to child trafficking. In these facilities, the staff at large was trained and had received a range of trainings around child trafficking. We found great variation in terms of the background of the staff, but I think it's interesting to note that the education requirements really varied for staff, some only requiring a high school diploma, some a bachelor's degree, and a small number of had either staff requirements of a master's degree or higher. Obviously, programs were seeking people with experience in child welfare, working with youth, but the salary ranges were fairly low. So in over half of the programs, the salary ranges for direct care were about $10 to $15 per hour. So even though these are specialized programs, the staff may not still be paid at what we might think about as a specialized rate. We also found a range of staff gender, that is that the majority, some of the programs had majority female staff, some of the programs had a mix of male and female staff, and interviewees actually discussed many of the pluses and minuses of both of those components. So there were strengths of programs having female-only staff, and there were weaknesses of those programs as well, particularly associated with sort of development of pro-social bonds between male clinicians or male staff members and young women in terms of commercial sexual exploitation. And so we found that there was not certainly one practice around staffing in terms of gender. The second component that we found was that about 85% of the respondents indicated that they participated in some way, and I really want to emphasize that in some way, with a multidisciplinary team response. So in the majority of cases, this meant that the residential facility participated with other people who are sort of illustrated in this visual: law enforcement, child welfare, therapists, legal counsel, health providers, the juvenile justice system, at various times in a team format in order to determine the best service provision for a young person who is housed in their facility. In some cases, a smaller number of cases, those were very formalized multidisciplinary team responses where there were regular meetings, regular communication, and an ongoing established relationship, sometimes with MOUs or other types of understandings where information could be shared. In other cases, the more sort of dominant model was that these were informal processes where teams were convened on ad hoc bases, that partners came in and out of that partnership. But participation with these partners in a multidisciplinary way was something that a majority of the respondents indicated was critical to providing services to child trafficking victims and that enhanced their response to child trafficking victims. 60% or so also offered that they provided a range of different types of wraparound services which were distinguished from participation in a multidisciplinary team. In terms of the physical space, what we found is that there was a real mix of where these programs were. You know, about 40% were in the city, almost the same amount, 38% were in rural locations, and about 20% were in suburban locations. And location particularly was something that directors talked about as being important, an important element of their response. And again, there were pluses and minuses, as you can see on this visual, to each. You know, the rural locations allowed youth to disconnect, but also may have reduced running behavior. The negative to rural locations was that they were oftentimes far away from where the young person was going to return, and that they may lose connection with important people in their life. So we didn't find, you know, that there was one model of suburban or urban or rural locations where these residential facilities were placed. We also found some real differences that I'm going to talk about when we get to safety, but in terms of the facilities being in more home-like settings. So many of the facilities were small, housing under 10 youth, and they were settings where young people could share meals and would be in a sort of more close family-like environment. Although there were a few programs that were very large and had, you know, a few hundred young people in them, not all of whom were child trafficking victims. So there was a range in terms of that physical layout. In terms of policies and programming, this is one of the places where we think that there was the most distinction between specialized programs and non-specialized programs. So specialized programs specifically talked about the fact that their programming is a large part of what makes them specialized, and that their therapeutic efforts were trauma-informed. And while there is some variation in the sort of application of trauma-informed services across the programs that we looked at, we found that Specialized programming involved individual therapy for young people, group therapy, clinical assistance. We found that these special programs also had some very distinct policies related to medical policies and also social media or cell phone policies. Now, I'll talk about that briefly since it's something that we certainly have gotten lots of questions about. And so we found, again, a range of what people allowed. A little over half of the programs did not allow young people access to cell phones or social media. About 20% allowed access, and then 14% had permission that was decided on a case-by-case basis. So again, directors of these programs discussed the challenges of social media and cell phone access and how to manage that. And just like merit systems used to allow students to, or young people to leave the facility in terms of staying overnight or going to visit family, we did find during the interviews that people talked about some gradated policies where young people maybe gained more access to use social media or cell phones in supervised ways to ensure that they were safe. And finally, I want to talk about safety. Safety was a major consideration for programs that were specialized. And one of the biggest features that we saw was that there was a recognition that young people will often go on the run or be missing from care, that it is a normal part of a young person's experience that is going through exploitation, and that there has to be plans in place to engage running behavior. That is, to talk about it, to have a young person know what is in place for them if they leave the facility and are on the run, and to actually put policies in place that allow safety provisions to be to go forth. And so about half of the programs that we looked at had specific safety planning around both physical safety of the young person and also safety if the young person is going to be going on the run. 86% of the programs that we looked at had some ability to hold beds for youth if they left the facility. And there was variation on this in terms of how long they could do that. And for many of the facilities, this is one of the places where private funding was key, that having private funding allowed them to hold beds for longer, and that they were able to let young people know that the bed would be available for them if they did leave, and that when they came back, they would have a place to stay. And 86% of the respondents also had specific recovery planning. So once the youth returned to care in the facility, they had a debriefing of the events, they went through medical clearance, then they did planning with the young person and with the multidisciplinary team around how to keep that young person safe now that they had returned, particularly if any adverse events or had occurred during the time that they were on the run, or things that occurred that had made them less safe when they returned to the facility. So there was this real direct engagement with running. Running wasn't necessarily something that people hoped wouldn't happen or tried to prevent, although people tried to prevent running from happening for longer periods of time and for people to being safe when they did it, when they happened to be leaving the facility. But there was a real recognition that young people in these situations where they're experiencing victimization may leave the facility, and that there needs to be policies and programming that provide for their safety in advance of that and when they return. So I want to talk briefly, we're going to talk a little bit about sort of what these findings mean. As I said at the very beginning, you know, we were able to identify a large number of providers. We got a sense that we were getting referred to the same providers over and over again. But it's possible that there are programs that either started after we initiated the study in 2018, or that we missed through this process. One of the things that we found, and I would really like to engage everyone who's listening today or who may listen in the future around, is that program directors were eager to have these conversations, in part because they felt incredibly isolated. That is, we found over and over again that programs were really trying to build specialized services completely alone. Maybe they knew one or two other programs that they happened to have contacted, but there was not a community of providers. There was not a set of best practices. There was not established standards. And so we found that providers really were seeking connection with one another. So there was no sort of population that we could go to and say, these are all of the people providing these specialized services. Mostly they're unknown to each other and lack the ability to share information. So we really hope this study is one of the first steps in starting to open that door of sharing information. As I mentioned at the beginning, we found incredibly limited data within these programs for documenting information about the youth who went through their program. So while most programs had some basic information about the youth that was collected at intake, very few programs systematically collected information about youth during the course of their stay in the program or did any tracking of young people after leaving the program. There were a couple of programs that had partnerships with researchers where they had more in-depth data collection, but that was not the norm in the overwhelming majority of programs that we looked at. So if we're going to get to the place where we know what best practices are, we're going to have to collect, analyze, and disseminate data about those practices. So I want to turn it over to Susan to talk a little bit about the sort of implications of this study for practitioners and providers within the child welfare system.
Thanks, Amy. So as Amy described at the beginning of the webinar, we set out to do this research because in our local community, there was an increasing interest in creating programming or identifying the programming that would be most effective and most supportive for this population. But we felt like that investment really required that we knew or had confidence that the elements that we were going to, that we could identify the right elements to create such an effective program. And as she also said in her spoiler at the outset, we didn't find the evidence basis that we hoped for or the degree of data that would support us fully. But I think we did feel, as Amy outlined throughout the presentation, that we did some of the elements that really rose to the top either validated what we knew intuitively or highlighted areas that maybe we weren't paying enough attention to and ought to pay more as we continue the effort to gather data and identify what in fact does have an evidence basis when it comes to providing these services. So quickly to recap, Amy spoke pretty extensively about the training, and the note that I would make there is that this kind of training for the staff that are working with these kids is not an hour and a half of CSEC 101. It is a more in-depth investment, and it's more than a single event. So I have a hunch that a lot of folks are already doing that, but that's kind of foundational and something that really is a very specific and important place to start. The references to the MDT or the multidisciplinary team, I'd like to think it's a wave that's overtaking the country, but I do think it's a growing movement of communities that are organizing in an official way to create connection among the agencies and providers who are supporting these kids. And in our community, we do have a very organized and deliberate intervention model that we call Support to End Exploitation Now, or SEEN. And it includes all the partners who are working with these kids and an MOU that does allow us to communicate. And I think the benefit for the kids is tremendous, and the benefit for the providers as well, because they have the opportunity to share information and put their heads together and brainstorm together with the youth's input when thinking about placement and housing. And I don't think that the decision around where a child is going to be placed can really be as effective without that level of multidisciplinary collaboration. That also ties into the case management, which is also part of what the team would be doing together, and a strong encouragement from what we learned from the programs, but also from our local experience to provide collaborative multidisciplinary team case management. This is more, I guess, at this point, anecdotal based on the input that we got from programs around the country, but And it's not a one-size-fits-all. Different kids are presenting with different circumstances, and different settings are going to meet their needs best. But in many circumstances, the idea of a smaller home-like setting that really created an opportunity to feel more of a family quality, and including the appropriate training and all the other supports, was something that was repeatedly referenced and that bears more attention and a look at. And skipping to safety, Amy talked about this quite a bit as well. And I think our first instinct in thinking about safety is to think about it in the absolute, that kids are away from harm and that we've removed the potential for them to be harmed any further. But what we know in practice is that we're really helping put supports in place that will prevent harm to the degree that we can, and also bolstering kids with skills and knowledge and resources and connections that will afford them more access to safety. And so I think a theme that came out of this report, as well as our own experience in our practice, is that safety shouldn't be looked at in the absolute. That, as Amy mentioned, running is something, or leaving one's home or one's placement is to be expected. So engaging youth in conversations about what will help them stay in place, what might trigger them to leave, and also thinking about what the response will be when they return, to foster an openness that will encourage their return and let them know that they'll be welcome, and thinking about safety more as something that we are continually striving to improve and increase, but it will not be an absolute, and won't necessarily be because there is a lock setting in a remote place with no ability for a child to be harmed in any way. I did get a special request from my colleagues here to also really reinforce, even though it's not on the slide, that practitioners should really be thinking about collecting data, and that in order to better understand the efficacy of what we're doing and to inform the programming that we're developing, that data is crucial. And I can reinforce the value and the tremendous benefit that comes from a research-practitioner partnership. And so I'm putting in my plug, and they're pleased that I am. Can I talk about that? Oh, I just thought we had changed the order. Okay. So next, shifting from the practitioner perspective to that of policymakers and child welfare agencies, the more big picture, the thinking really is that this does require resources, and probably a significant allocation of resources, which speaks again to the need to have the information and the data to put those resources in the right place. But as we're learning and as we are striving to create more effective and supportive settings for these kids, it is important to allocate specific resources both for the research of what will make the most sense and then the implementation of those programs. We're strongly encouraging that if you don't have multidisciplinary collaboration in your community, that you really start taking steps to think about or take action to make that happen. In our community and in our state, our multidisciplinary teams are based in our children's advocacy centers, and that's a really natural place for teams to convene around this issue. Those teams and the partnerships really establish a connection among the agencies that is invaluable. And again, we are highly recommending structured connections among and across agencies to be able to share resources, conduct the kind of research that helps advance the field, and improve the services, and also mutual support for all of us that are in this work together. There was mention of the critical importance of having survivors on staff, and also some obstacles to being able to do that. For example, laws or policies within a particular state or jurisdiction that prevent employees with a criminal record. And our recommendation is that programs and communities should consider reaching out to programs that are already working as survivor-led or survivor-informed programs to get their advice and guidance and technical assistance, and also advocacy to change laws that would prevent engaging survivors in programming. And I think finally that we all, as I mentioned before, consider partnering with a researcher to advance practice together, and also that collectively we carve out avenues for sharing this information and creating broader networks in forging ahead with this and identifying what makes sense I think our local practice was greatly enhanced by having a partnership with our colleagues on the West Coast. And throughout this process, we had the ability to confer with them and to have the benefit of their experience as well as ours. And that was also really, really helpful.
Thanks, Susan. Just to wrap up for those on the webinar today who are from the research community, because I know that there are a number of you, we have a few recommendations, not only about the engagement in partnership relationships, but for those researchers who are doing that engagement, the encouragement to use the strongest research design that's possible, including where appropriate and ethical comparison populations and random assignment. These are tricky processes, but if we're going to get to places where you have promising or best practices that can be established and supported by funding, we need to be able to try to use the strongest designs possible. We also encourage the incorporation of longitudinal follow-up with young people who have been engaged with programs, and to echo not only the role of survivors in the policy and planning process in the development of these programs, but the role of survivors and young people's voice in the research. So that is the ability to have feedback from youth about their experiences going through programs to ensure that evaluations are grounded in their personal experiences. And to ensure also that the right types of data that represent their successes and their challenges are included in any system where we build data management to collect longitudinal data on young people. And also that the field really needs to support the development of a common set of outcome measures that include both system-level outcomes and outcomes for young people that can be reasonably collected by agencies or programs, and that would provide the information necessary to improve the practices of these specialized programs and to improve outcomes for young people. So that's an overview of the study, and we're delighted to have a little bit over 10 minutes to take questions.
Perfect. Thank you, Amy and Susan. So we do have several questions that have come in. So I'll just start with the first one. Wondering if a list of the programs you spoke with will be available, and then more specifically, if those programs that were identified as providing specialized services to victims, if that, you'll be able to decipher which programs provide those.
That's a great question. As we were doing interviews, we did specifically ask if programs would consent to be part of a list that was sent around. A few said yes and a few declined. We are in the process of going back through those lists so that we can put them in a concise place. We are also hoping that that can extend into a larger network that people can become a part of in a central place so people can navigate who in the country is doing this work, and if people see that it's building, that they themselves, if they decline it on the offset, that they include themselves later on.
Thanks, Sarah. And I would also echo something that I mentioned earlier, which is that there's I guess in speaking to federal funding agencies or others within state governments, that, there's a real need to support across states the development of a community of providers that provide specialized programs within residential settings to share practices, not only to develop connections, but to build a body of expertise. And it was something that interviewees, again, said time and time again, and people participated in the research in part because they were interested in being part of the development of that connection.
Excellent, thank you. And I am going to continue with the questions here, but I do want to go ahead and have us launch our poll. This is our evaluation poll for the webinar. We do have to report this to OVC, so please take a moment to respond to the poll. And if it kind of gets in your way there and you can't see the chat box, you can click on that arrow next to chat to open that back up for you. But we do really appreciate your responses. So the next question we have is, kind of a long one. Does your local MDT operate with the Child Advocacy Center systems, and do all participants have an MOU to share case information, privacy concerns like HIPAA, any specialized linkages, linkage agreements to share that information? Does any one agency serve as a care coordinator for coordination for these children's cases? So this might kind of be a question out to the group there as well, but if any of our presenters have comments on those, and let me know if I need to repeat anything.
Sure, you might. So this is Susan, and I can speak for our local MDT. So it is based in our CAC, and in our state there is now a CSEC MDT based in the Children's Advocacy Center in every county. And the way in which, so there is a formal MOU for us that outlines our shared mission and purpose, and then the roles and responsibilities of each participating agency. And that's something that we designed collectively with our partners and vetted with them, and then is sanctioned and signed actually by their agency lead. Central within that and how we operate within Massachusetts is that our statutory, our MOU, our protocol for referring and bringing cases to the MDT and then communicating among MDT members is rooted in our statutory structure related to child welfare reporting, reporting a suspicion of child abuse, neglect, or exploitation, which creates a connection between that report, the Department of Children and Families, and the partners on the team. So that was very intentional, knowing how important communication is among team members. And so we use that as the foundation of our shared information, and in circumstances in which an agency might have other restrictions or want to have consent from the client or their guardian, that would be pursued in addition in order to afford communication. And just to speak to the question of the case management, the case coordinators for our multidisciplinary team are based in our Child Advocacy Center, and that is their specific role.
Great, thank you. I think you covered all of that nicely. The next question we have is, can you speak to the need for cultural competencies and if there is a need for diversity training among practitioners?
Yes, hi, this is Sarah again. That was an area actually that many providers spoke about without us prompting, that they felt that they needed to have diversity amongst staff in order to make sure youth felt represented in language as well. Nobody specifically brought up training, but I think that they would all be very open to that as a segue to not only talking about this population, but how cultural needs play into their recovery. Mostly the discussion centered around staff diversity and making sure that if they brought in external mentors, that was another way that they could also bring in representation, and giving youth mechanisms to connect with adults who mirrored them both racially, ethnically, and with their gender identity. So those were all areas I think that practitioners felt that, but they didn't explicitly speak to training.
And likewise, we didn't spend as much time in the actual presentation talking about it, but we do spend some time in the report talking more about the variation in the role in which the experiences of survivors is integrated into both the training, the development of policies, and the actual practice of providing services to young people. And so, as Sarah mentioned, external mentors or survivor mentors are one way in which not only there is an understanding of the experiences of people who may have different lived experiences, but also may come from a wide range of different types of communities and have different community experiences.
Great, thank you. Our next question is related to trainings. Wondering if a list of the trainings that some of these programs use for staff, if we could send that along or if those are in the report.
So the training piece, as we alluded to earlier, is a little bit difficult. Many of the programs explained that a lot of their training is developed internally. It's based on their own experiences, and while they might have picked up some external trainings and ideas from conversations with other providers or at conferences. A lot of them are not formal in the sense that they would be able to be readily sent around. There are obviously formal trainings that people have tapped into that I think we would be very happy to disseminate the list that we do have, but those are pretty limited in what was provided to us. I think if a network was established, that would be a much better mechanism, to get those trainings shared amongst providers.
And as we see, I mean, I think we see resonance of this within law enforcement and law enforcement training. You know, it's fairly easy to have the boilerplate, you know, child trafficking 101, spotting the signs, understanding and awareness training that might be a, you know, a shorter overview. The real challenge is this deeper training that is rooted in practice. And as Sarah mentioned, these were the places where you know, there were not necessarily like off-the-shelf versions. This is also a place where the interviewees suggested that, you know, that they were sort of you know, making it up as they went along, and there was a lot of like, this has been our practice, and so this is what we've seen internally, and this is really related to what's happened in our experiences. And there was a real desire to find out if those are the experiences of people in other residential settings, and to really understand if what they're training their staff on is something that is supported by evidence. And I think that's one of the limitations of where we are. You know, we want to train everyone, and we're not sure necessarily until we do more evaluation on the special components of these programs to really know some of what that training should be.
Great, thank you. Our next one is wondering if you have recommendations for conducting research within the MDT care coordination efforts.
Yes, I mean, one of the things that I have been lucky to be is part of part of our multidisciplinary leadership team here in Massachusetts, and what has meant is being deeply involved in all of the work of the leadership, and I think that that's been really important in terms of the evaluation. It has given us access as researchers to develop data collection systems. It's given us the ability to work in close collaborative partnerships with people who are on the ground providing services and coordinating care to ensure that measures that we establish, questions that we ask are representative of their experiences. And I think we can bring to that table situations where there are, you know, validated measures that we might want to integrate, and practitioners bring to that table knowledge that those instruments won't work in their practice, or would be cumbersome to use, or would be traumatizing, or would have negative implications. And I think, you know, not having that researcher be somebody who's brought in after you've already designed your program and after you've already been operating and after you are already doing all the things you're doing, but being brought in to help with some of the planning, to provide research in what I would argue should be an action research model, where information is being fed back to the program or to the team in order to help change or inform practice. At the same time, that there's a real value for research that can be systematic and neutral in many ways. You know, where findings can be recognized as being valid. So the role of those researchers, I think, as we've talked about the development of a community of practice, there is an equal need, and I think some real efforts that have been supported by ACF and HHS to develop a network of communities of researchers who are working together to try to overcome the problems of how to develop the type of research that will be meaningful to the field of practice.
Great, thank you. This is a quick reminder for everyone still on the line here to fill out the poll if you have a chance. We do have a few more questions that I'll go through here. The next one is related to housing. So how do your MDTs work with the housing options when they are not local?
The first thing I'll say is that there are folks on our staff who are more directly involved in this, who, if they were here, would be able to give you a more specific answer. What I can tell you more globally is that on our SCENE team with our case coordinators and our SCENE program manager, Beth Bouchard, they've actually developed relationships and a network that extends beyond our state and into other states that have facilitated not only recovering youth, but also supporting youth when they're out of state. And so I think something that we've wondered and thought about increasingly, what it would be like to have a network where people, point people, case managers or others doing this work would actually be able to go to a resource and know who to contact in another jurisdiction. We are not, as the CAC, the entity that places kids and determines their placement. We're the folks responsible for coordinating those who are having that conversation. So the placement decision itself is most typically made by our child welfare agency, and they have obviously natural connections in other states. But it is really the network that has been invaluable. And I will say, too, that I think it's unusual that we're looking to place kids out of state, that the vast majority, if they're not remaining at home, are staying at a placement close within our jurisdiction.
Great, thank you, Susan. The next question we have is, are there any existing surveys that you all would recommend?
Surveys in the sense to conduct similar research as this, or?
I'm unsure. If whoever asked that question, if you want to provide, if you're still on the line and want to provide some clarification on sort of the type of survey you're alluding to.
One thing I will say is the surveys that we used for both the preliminary survey and the in-depth was a collaborative effort through the 3 entities here. It went through quite a variety of discussion about what should be asked, what shouldn't be asked, what is most relevant, but it was grounded in what the folks on the West Coast were doing, but we adapted it ourselves. And so in terms of validated surveys that have been put out, I know that there are a few surveys that have been conducted before looking at national landscapes, but I'm not sure if that's the survey that they're speaking to.
The other thing that someone may be alluding to is there are a variety and growing number of assessment tools we might think about survey questions being asked of individuals who when they were intaking them to determine whether or not they were victims of trafficking. So there are a variety of screening tools. One of which was designed by Vera for both adult and children trafficking victims, one of which was recently tested by HHS for children in child welfare and runaway homeless youth populations. There's also the West Coast Clinic screening tool, assessment tool. So there are a variety of tools that have been developed, as well as a tool within CANS to assess the degree to which young people might be victims of trafficking.
Thank you, Amy. We did get some clarification on that question. They were wondering about the longitudinal portion for the child participants. So I know you had mentioned there wasn't much data about them, especially after receiving services. So are there any good surveys for that portion? And perhaps you just mentioned one.
Right. So those that I mentioned were actually not longitudinal. Those are assessments. So those are sort of done at the point of intake or shortly thereafter the point of intake. In terms of longitudinal studies, so I've been part of a study with Boston University that Emily Rossman is leading, where we've been looking at longitudinally following young people who were commercially sexually exploited after their interventions with services. And the National Institute of Justice will be releasing that study within a few months. And I know that the instrument for that survey will be available at that time. And that's a survey that we developed based on the utilization of some validated measures about outcomes for youth, but also that we created with a huge amount of survivor input and input from programming that works with young people who have been commercially sexually exploited in order to develop the measures.
Excellent. Yeah, we'll have to make sure we get that into the CVR instruments collection as well. I know we're a little bit over time here, but there are a couple more questions, so we'll try to get to those here real quickly. So the next question is related to the sharing of the resources, such as engaging kids who run. Will you guys be able to share those? It sounds like you would be able to.
Some of that is more detailed in the report, and so we certainly will be making that available to all the participants.
Excellent, thank you. The next question is, this person is a coordinator of CSEC MDTs at a CAC. However, collaborating with placements is challenging as they are not included in MOUs or protocol. Any recommendations on how to still work with, incorporate placement providers?
So this is Susan. I guess my recommendation would be to engage them and add them to the MOU. I think, I'm not saying that to be cheeky, I think one of the strengths of our multidisciplinary team and many across the country is the diversity of the partners who are engaged in that team, and that often means including what might be considered non-traditional partners, or even partners who might require specific consent from the youth or their guardian in order to be part of the team. But I can't reinforce enough how important and valuable it could be to expand the MOU and the team in order to have those placement partners as part of the conversation. And I'm optimistic that if there are any differences that make that difficult, they can be overcome.
Great, thank you, Susan. So we had another question. Your thoughts on including churches as MDT partners. Is that something you've seen or would recommend?
So the only way I can really speak to that is a lot of the providers we spoke to are faith affiliated. So in that sense, the church tended to be a partner already in the sense that they were already affiliated with where youth were placed. I think that would be very community and needs specific because obviously there's a wide variety of religious and faith-based needs of youth. To include them across the board, I think we wouldn't be able to blanket that very readily, but for those who already made sure to provide religious and faith-based services, that was a part of the programming more so than the MDT response.
And I would just echo that again, whether the degree to which you provide survivors in different aspects of this, the degree to which you have affiliation with religious organizations, who the partners should be on the MDT, a lot of these questions are questions that we have some thoughts from experience of the people that we interviewed and the people on the team about what seems to be working, but we really do lack data that shows that different types of responses in different types of contexts produce different kinds of outcomes. So many of these questions about whether or not something would be good or bad, we can't, as necessarily social scientists, speak to without much better information on this.
Yes, definitely. Sounds like there's a great need for some program evaluation work out there. One final question. I appreciate you guys staying on a little over here. The question is there a national data bank on this population?
No. You mean on the population of providers, or there is not currently a national data bank on the population of providers, and there's not a national data bank on young people who've been commercially sexually exploited or child trafficking victims. No. No, so on the children, no, there's not a national data bank on children who've been commercially sexually exploited.
Okay, thank you. I think I got all the questions. I apologize if I missed anybody. I will read back through the chat, and if I find one that I missed, I'll make sure that we email you and get you an answer to your question. Thank you, Amy, Sarah, and Susan so much for your presentation. I know that I learned a lot, and I look forward to reading the final report. And thank you, everybody, for joining.
Thank you.
Thank you.
Okay, take care, everyone.